forget. Before I get started, I just wanted to discuss some housekeeping items. Later today or this evening, I'm going to be sending you a test blueprint for the exam next week or the week after. I don't know when you all are doing your exams because everybody's different. But I'm going to go ahead and send you a blueprint. This blueprint is very helpful for most people. It will tell you which of the outcomes I'm going to measure and how many questions are based on each. So that can really help guide your study and what to focus on, because that's usually the most common question I have is what to focus on. The other thing is I'm going to offer a virtual exam review. I'm going to offer one Thursday at 6 p.m. and I'm going to offer another one Monday at 6 p.m. I'll also be recording these sessions as well. So if you can make it, please come. If not, you will have access to the recording. So I promise you, I'm giving you all the tools to help you be successful on the exam. All you have to do is some studying. But I'm usually people do very well on the exams as long as they put the effort in and do study. So any question about the exam? It's going to cover modules 1 through 4. So after today, this will cover all the material that we'll have on this first exam. Okay, if there's no questions, we'll go ahead and get started. I also want to just remind you too that quiz 2 is available, and that will need to be completed before Sunday at midnight. When I send you the exam blueprint, it will show you how many questions are on the exam. I can't remember offhand, sorry about that, but it will show you on the blueprint. So that will come via email tonight. Okay, so with that being said, let's go ahead and delve into the newborn period. First, we're going to talk about normal newborn adaptations, and then we're going to talk about normal newborn care. So beginning with normal newborn adaptations, so right after delivery, we go ahead, we clamp the umbilical cord, and the infant's going to take their first breath. And that really begins what we call the transition period, which is generally anywhere from 2 to 6 hours. And this transition period is really the adaptation of the newborn from the intrauterine environment to the extrauterine environment. So remember, when this baby's been in utero, the placenta has functioned as the lungs, and they've gotten their nutrition from the placenta as well. So once that cord is clamped, they're no longer getting the oxygen, the nutrients from the placenta anymore. So they have to adapt pretty quickly to a new environment, away from the warmth and the protection of the uterus. And as I mentioned, this transition period usually lasts about somewhere between 2 to 6 hours. Okay, so we actually have a number of factors that combine to stimulate the respiratory center in the brain, and that helps initiate respirations at birth. So the cues to start breathing are going to be mechanical, they're going to be chemical, they're going to be thermal, and they're going to be sensory. So the chemicals that are going to cue breathing in the newborn are going to be carbon dioxide and oxygen. So as soon as that cord is clamped, the placenta again is no longer providing the exchange between oxygen and carbon dioxide, and that creates a mild period of hypoxia. It's very similar to holding your breath. And then we have an increase in carbon dioxide, which causes a little bit of acidosis, and that stimulates the respiratory center of the brain, which stimulates breathing. So those are our chemical factors. Next, we'll talk about mechanical factors. So during the fetal life, we have the alveoli that actually produce fetal lung fluid, and that's what aids in lung development. So even though they don't need their lungs in utero, they do need them once they're born. So again, we want to make sure that these lungs are developed. We also have surfactant. Surfactant is kind of like the glue that keeps the alveoli open, and that lines the alveoli and reduces surface tension, and again, in order to keep those alveoli open. The lungs of the newborn are going to have fluid in them. One thing that does happen though is as the pregnancy gets closer to term and during labor, a lot of this fluid is going to be expelled, and fluid actually decreases as that pregnancy gets near term. And then during labor, it's going to decrease because some is expelled from the lungs as the fetus is squeezing through the birth canal. And after delivery, the rest of the lung fluid is going to be absorbed by the lymphatic and the vascular system. And this may take up to 24 hours. So sometimes when you first do your assessment, the lungs are going to sound a little wet. And that's just because there's still some fluid on the lungs. You especially see this in babies who had a cesarean delivery and didn't undergo labor because they didn't have that squeeze through the birth canal. As far as thermal, with birth, the neonate basically goes from this warm liquid environment to one that's pretty dry and it's cooler. And the newborn actually begins losing heat through several mechanisms, which we're going to talk about in just a little bit. So the change in temperature is also believed to stimulate the respiratory center of the brain. So the change in temperature is the thermal mechanism that helps initiate breathing. And then we have sensory. So the sensory cues include things like lights, smell, sound, actually handling the newborn, suctioning and providing stimulation, and all that's believed to trigger the respiratory center. So what you need to take away from this is just know that there's 4 cues that initiate breathing: chemical, mechanical, thermal, and sensory. Here's just a little diagram where it shows you the internal stimuli, like the decreased oxygen, the increase in carbon dioxide, the decrease in pH that affect the chemoreceptors, and then that causes a message to be transmitted to the brain. The diaphragm is stimulated to contract, and that infant takes their first breath. And then we have external stimuli, where we have that cold air, we have that thermal and sensory cues, and this causes impulses from the skin sensors, and which responds to sound and light, and that again initiates that first breath. And then that chest compression and release during birth really causes that fluid to be expelled in the lungs to be able to draw in air. Okay, the next thing I want to talk about is the cardiovascular adaptation. So if you remember from our first class, there was a little video on the newborn circulatory system, or a little, a little narrated module that goes over the neonatal circulatory system in utero, which we know is different and it functions differently than after delivery. So just as we discussed the significant changes that have to occur to initiate breathing, there's also significant anatomic changes that must occur at birth to just establish this mature circulatory system. And it's important to know that the respiratory and the circulatory system are not mutually exclusive, because respiratory changes are going to influence changes in the circulatory system. So those first breaths that the baby has, the first breaths that are going to expand the lungs, but they're also going to dilate the pulmonary vasculature, and that's going to reduce pulmonary vascular resistance. So this actually results in an increase in blood return from the lungs to the left atrium. And now the left atrium is higher in pressure than the right atrium. And that causes the foramen ovale, which is a small hole in the wall between the two atria, that causes it to close. And then at the same time, we have systematic vascular resistance that increases because of the clamping of that umbilical cord. So once that cord is clamped, we have blood flow through the ductus venosus. It begins to actually atrophy. So we have then closure of the ductus arteriosus, and that shunts blood from the pulmonary artery to the aorta. That happens more slowly. Sometimes it's over days or weeks, and it's likely going to be influenced by hormonal, chemical, and pressure processes. Anytime we have conditions such as asphyxia, where there's insufficient oxygen and excess carbon dioxide in the blood and tissue, or if we have persistent pulmonary hypertension, any of these conditions may reverse the pressures in the heart, and that can actually cause the foramen ovale to reopen. But we're going to discuss more about these changes when we get to Module 12 and we talk about complications in the newborn. All right, so thermoregulation. This is a very important topic when it comes to newborns. That's a hint. So newborns have a higher ratio of body surface to body mass than adults. They also have skin that has very little subcutaneous white fat. And because of that, there's not a lot of the blood vessels are very close to the skin, and that puts newborns particularly at high risk for hypothermia. And so because they're at high risk for hypothermia, they can also have heat loss that can really affect their thermoregulation. So infants can actually lose heat through 4 processes. They can lose heat by evaporation, conduction, convection, and radiation. And we're going to look at these individually because I want you to be very familiar with the methods of heat loss and what they mean and what we can do to help prevent that. So with evaporation, this is when we have heat loss due to the evaporation of liquid from the body. So immediately after delivery, you know, the baby's still covered in amniotic fluid. They're wet. So one of the things we want to do is make sure we dry them immediately after birth. Drying them will help prevent heat loss, and at the same time, it kind of stimulates the baby. So it gives you some stimulation to help them breathe and cry and again, clean up some fluid of their lungs. So we want to dry them immediately after birth. Another thing we want to do to prevent evaporative heat loss is when they have their first bath, we want to make sure that they already have a stable temperature. So for example, at my hospital, we don't bathe babies until they're at least 8 hours of age, because that's usually when their temperature starts to get a little more regular. We don't ever bathe a cold baby because we know that they can lose heat with evaporation. And again, when we do bathe babies, we want to make sure that we're bathing them in warm water. So that's the heat loss through evaporation. And one of the things too I want to mention is when we do dry the baby, we're getting rid of those wet linens. We're tossing them aside, so we're always drying with warm linens. And we usually have these linens under the radiant warmer, which helps keep them nice and warm. Okay, the next one I'm going to talk about is conduction. Conduction is the transfer of heat by direct contact with a cooler object. So what does that mean? It means if we put a baby on a cold metal scale or a cold scale, they're going to lose some of that heat through conduction. So some of the things that we do to help prevent heat loss through conduction, we make sure that we put maybe a warm blanket on the scale. We can actually zero out the weight of that blanket so it doesn't interfere with the weight of the baby. So we can zero that so it doesn't include the weight of the blanket and get a good weight on the baby. So don't put them on a cold scale, nice warm blankets. We always preheat radiant warmers, as I said beforehand. So again, we have everything that's nice and warm. Even when I go to listen to their heart rate, because we always do an apical pulse for newborns when we listen to their heart rate, I even go ahead and I warm up my stethoscope as well and make sure that my hands, you know, are warm. I always wear gloves, of course, but I just wouldn't want to touch a baby with cold hands. The next type of heat loss is called convection. And this is when we have heat transfer from the newborn to the surrounding air. So basically, if we have drafts coming in and hitting the baby, that's going to cause heat loss through convection. So a couple things we can do. First of all, make sure we have a nice warm room, and then avoid having any air currents from open windows or fans or anything, or too close to I'm trying to think, vents too close to vents where they might have some cold air blowing. So just keeping the baby again nice and warm, making sure that they're warm room and that we don't have no drafts on the baby. And the last one I'm going to talk about is radiation. Radiation is when the infant is close to a cold surface and they're losing weight to that cold surface. So it doesn't touch the baby, but let's just say you have the baby's crib on an outside wall, so a wall that faces outwards, and it's a cold day. Even though that causes the window to be cold, maybe even causes the wall to be cold. And even if the baby's not in direct contact, they can actually lose their heat through the process of radiation. So a couple things for there. We want to keep the babies away from exterior walls or cool windows, anywhere that they can actually lose heat through the process of radiation. So you do want to be familiar with those 4 types of heat loss. I also want to talk about non-shivering thermogenesis. So newborns typically aren't going to shiver like adults, and they have to produce their own heat by the process of what we call non-shivering thermogenesis. And that requires the mobilization of something we call brown fat or brown adipose tissue, and that can actually double the heat production. So babies, a healthy term newborn is going to be born with some brown fat in them. And it's usually going to be located at the neck, the axilla, between the scapula, along the abdominal aorta, around the kidneys, the adrenals, the sternum. So that's usually where these reserves are kept. And as I said, these brown fat reserves are more abundant in term newborns, but once they go through these brown fat stores by trying to stay warm, that becomes completely depleted. And so they no longer have that brown fat to metabolize to help keep them warm. Anytime we have preterm infants or infants who are have intrauterine growth restriction, meaning we have a small infant, they may have inadequate stores of brown fat, and what stores they do have are depleted pretty rapidly. Anytime that you have a baby that's experienced some hypoxia or hypoglycemia or acidosis, that can all interfere with the baby's ability to generate heat. And these infants are not able to raise their body temperature, which can result in what we call cold stress, which is a very serious complication. So what is cold stress? Well, anytime we have an increase in the metabolic rate and the metabolism of that brown fat, that can increase the need for more oxygen. And if the newborn is even having, mild respiratory distress, the problem is increased because they have to use more oxygen for heat production. So again, this increases their oxygen needs, and that can lead to respiratory distress. Also, that cold, anytime they experience cold stress, it will also diminish the production of that surfactant, which is the glue that helps the lungs alveoli to stay open. And if we don't have that, that can impede lung expansion, which even causes more respiratory distress. The rise in the metabolic rate means glucose is needed to produce heat, and that can deplete the glucose stores pretty quickly, which can lead to hypoglycemia. So again, cold stress. Babies has to increase their oxygen demands. They have to increase their metabolic demands. So they're really having to burn a lot of these calories and the brown fat and the glucose just in order to stay warm. And okay, again, it's going to deplete very, very quickly. Another thing about the brown fat, it releases fatty acids, and that can cause metabolic acidosis, which is a life-threatening condition. And the fatty acids also can interfere with the transport of bilirubin to the liver, which increases the risk of the newborn having jaundice. And I know most of you know jaundice, but it's basically a yellow discoloration of the skin and the sclera of the eyes that's caused by excessive levels of bilirubin. All right, next I want to talk about hematologic adaptation. So term newborns are going to have a higher hemoglobin concentration than adults or even older infants, because while they're in utero, they have less oxygen available to them. So in order to increase the oxygen carrying capacity, they produce more red blood cells. So that's why they have a higher hemoglobin and hematocrit. Now, fetal hemoglobin does differ from adult hemoglobin. It has a much shorter lifespan, so the hemoglobin and the hematocrit levels drop quickly after birth. Um, and again, when all these blood cells are breaking down, which is a normal process, the byproduct of broken blood cells is going to be bilirubin. So this is why we have an increase in jaundice for infants. Infants also, newborns can also have leukocytosis. Which of course is the elevated white blood count, and sometimes it can be as high as 9 to 30,000, and that's pretty normal at birth. It usually increases in the day after birth before it starts to decrease. The other thing about the hematologic system is clotting factors are low during the first days of extrauterine life, and that's due to a low level of vitamin K. So vitamin K is usually obtained as a byproduct of gut bacteria, and they get it through their diet. So at birth, the newborn gut is pretty sterile. It doesn't have any bacteria present to create vitamin K. Also, vitamin K doesn't cross the placenta in utero, and there's very little in breast milk. So they really don't have vitamin K stores to use, and that increases the risk of bleeding, especially intracranial hemorrhage. Newborns have a very fragile network of vessels in their brain called the germinal matrix, and it's a high risk for having intracranial hemorrhage. And so we actually will give vitamin K to newborns at delivery, and that protects them until they're able to produce their own vitamin K. And usually they can produce their own vitamin K by about 8 days of life. But this is one of the newborn medications we give to every newborn just to help prevent intracranial hemorrhage. And it's made a huge impact on the number of infants who have previously passed due to intracranial hemorrhage. So we don't see it as much anymore. And that's because we started giving them vitamin K at delivery, after delivery. Within about the first couple hours, we give it. Okay, the gastrointestinal system. So at birth, the stomach of the newborn is quite small. It's really about the size of a marble or a large blueberry. So the stomach capacity is only about 5 to 10 mils. So again, babies don't need to have a lot after birth. You know, they can't really accommodate more than 5 to 10 mils or they'll spit up. The stomach capacity does quickly increase to about 60 mils within about the first week. I also want to talk about the stools. Meconium is the first infant stool. That's the first one you'll see. It's very thick. It's kind of like a greenish black color. It's very tarry. It's very sticky, and it's typically passed within the first 24 hours. Sometimes we have newborns that have actually passed meconium because of hypoxic stress in the uterus. So that's when we get meconium stained fluid. Anytime baby's been exposed to some sort of hypoxic event, it usually will relax their anal sphincter, and as a result, they usually pass meconium in utero. So that's important to know as well. The stool changes through the next couple days from a greenish black to more of a greenish brown by the third day, and we call that transitional stool. And by the end of the first week, usually the stool of breastfed babies, so babies who've only had breast milk, tend to be mustard colored and kind of seedy, and they usually don't carry a strong odor, whereas the stool of formula fed infants by the end of the week is usually browner and kind of has a more unpleasant odor, and it's definitely more formed than the breast milk stools. Okay, the hepatic system is also important. It has several important functions. First of all, it maintains blood glucose levels. It's also needed for the conjugation of bilirubin. So I talked about how these red blood cells break down quickly after birth, and the byproduct of that is called bilirubin. Bilirubin is actually in its unconjugated form right there, so it can cause jaundice. And what happens is the unconjugated bilirubin binds to albumin and it goes through the liver. And as it does that, it becomes conjugated, it's conjugated bilirubin and becomes unconjugated bilirubin. So it's conjugated, it binds to the albumin, it goes through the liver, and it becomes unconjugated bilirubin. And that's what can be excreted through the diapers, like through the stool from the bile and so forth. So they can get rid of it that way. But it's still a pretty immature liver. It's a young liver. It really can't keep up with that byproduct of bilirubin very well. So this is why most infants are going to have some form of physiologic jaundice within the next, 3 to 5 days. And that's just because, again, their liver just has to work harder to get all of that bilirubin conjugated. Let's see here. Production of factors necessary for blood coagulation. We talked about that. Storage of iron, and of course, just like adults, metabolism of drugs. So those are the important functions of the hepatic system. I also want to talk about blood glucose maintenance. So the production of new glucose from non-carbohydrate sources happens primarily in the liver. So in utero, maternal glucose can pass through the placenta and get into the fetal circulation, but one thing that doesn't pass is insulin. So when we have moms who are maybe diabetic, we have a harder problem with blood glucose maintenance in the newborn. So the glucose is passing to the newborn, but the mom's insulin is not passing. And as a result, the baby creates their own insulin to deal with this high sugar environment. Now, what happens then is once this baby's born, we've cut off that glucose supply, but the newborn continues to produce insulin from the pancreas just as it did in utero. But without a regular supply of the mom's glucose, it's going to cause an immediate drop in the newborn's glucose level. So they can bottom out in about 60 to 90 minutes after birth, which then generally will stabilize over the next 4 days. So not women. Infants who are at increased risk for hypoglycemia include newborns who are preterm, also small for gestational age, which means once we plot their growth according to the gestational age, they fall below the 10th percentile. We also can have infants who are large for gestational age. So again, once we plot their weight and length and head circumference, if they're above the 90th percentile in weight, then we consider large for gestational age. We also, babies born to diabetic mothers, babies who are exposed to stressors, and also babies who are experiencing cold stress. So these are all the babies that are at high risk for blood glucose. Usually, as long as it's above 45, that's great. So it's a different number than you would expect to see. You're used to hypoglycemia in adults, but hypoglycemia in the newborn is below 45 milligrams per deciliter. So I talked a little bit about jaundice. So I want to talk about the differences between physiologic jaundice, which is that normal jaundice that 70 to 80% of newborns have, and pathologic jaundice, which means that it's a pathologic cause. It's not normal. Okay, so physiologic jaundice is common to some degree in most term babies, and it's even more common in preterm babies, and it often resolves without treatment. So I talked about bilirubin. It's really a normal product of the breakdown of the red blood cells. And then the bilirubin is normally conjugated in the liver, which allows the conjugated bilirubin to be excreted. So if not enough conjugated bilirubin is excreted, we actually start to see jaundice. And usually jaundice progresses from the face and the sclera. And then as the levels get higher, it starts to descend down the chest, the abdomen, and the extremities. So newborns are particularly at high risk for high levels of unconjugated bilirubin because of the high volume of red blood cells, the short lifespan of the red blood cells, and the limited ability for the liver to conjugate bilirubin for excretion. So we do, it's not unusual to have physiologic jaundice, but there's a very important difference between physiologic jaundice and pathological jaundice. We're going to talk more about pathological jaundice in module 12 when we talk about this newborn. But at this time, just note that normal physiological jaundice appears after 24 hours and is a normal physiologic response. Okay, so it shouldn't appear before 24 hours. Pathological jaundice, on the other hand, is jaundice that begins in the first 24 hours. So we start to see it before they even reach 24 hours of age. And that causes even more bilirubin production. And it's usually going to be related to a disease process. We have to really monitor and treat this more closely. And also remember, pathological jaundice is still going to be superimposed on physiologic jaundice. So again, the one thing I want you to remember is just pathological jaundice in the first 24 hours, there's a disease, it's part of a disease process, whereas normal physiologic jaundice is going to occur after the first 24 hours. Any questions about that? All right. I also want to talk a little bit about risk factors for elevated bilirubin. So again, we talked about they have an excessive production of erythrocytes. So they usually have twice as much produced than adults while they're in utero. We have a very short red blood cell. Fetal red blood cells break down more quickly. We might have a lack of albumin binding sites because newborns actually have few albumin binding sites. And anytime you have decreased albumin binding sites, you can't you can't attach to the albumin to go through the liver to become conjugated. Liver immaturity. So again, they have liver limits. Their immature liver really limits the amount of bilirubin that can be conjugated. Pathological jaundice, one of the common causes besides the disease process, can also be a blood incompatibility. And this usually occurs if mom is a type O blood and baby is a type A, type B, or type AB blood. That causes a blood incompatibility, which can lead to pathological jaundice. It's one of the causes that can lead to pathological jaundice. We talked about preterm infants, so they have even more immature conjugation abilities. And then also we have a lack of intestinal flora. So again, the bowel is sterile, and that hinders excretion of the unconjugated bilirubin, and that's usually related to delayed passage of stool, because meconium is really, really high in bilirubin. All right, so other risk factors for elevated bilirubin: delayed feeding, because delayed feeding causes delayed passage of meconium. It could also be done. It could also be higher risk if there's been any trauma, like bruising. Bruising, or what we call a cephalohematoma. So there's two different things we look at in a newborn assessment. We assess for caput, which is just a fluid collection under the head, versus a cephalohematoma, which is actually a collection of blood under the scalp. And sometimes that can happen with, more traumatic births that have a little bit more trauma to it. And because of that, they have a higher collection of red blood cells that are going to break down, so they have a higher risk of getting elevated bilirubin. So one thing that you'll want to review is the difference between a caput, which again is fluid under the scalp, which is going to absorb and go away. But in the meantime, I like that it's called caput, because you think about wearing a cap, that means it covers the entire head. It's not, limited to suture lines. Whereas if it's cephalohematoma, it does not cross suture lines. So usually it's going to be on one side or the other. It's generally not going to be on both sides. We talked about fatty acids from cold stress or asphyxia, and fatty acids have a greater affinity than bilirubin for the binding sites of albumin. So they bind the albumin before bilirubin, and then bilirubin can't be carried through the liver to become conjugated. Certain family backgrounds, there's an increased risk in newborns, Native American, Eskimos, and in newborns who had a previous sibling with jaundice. Other factors might include diabetic mother, some of the drugs, hypoglycemia, or infection, which can be a pathological jaundice. So pathological jaundice usually has two underlying causes. It's either infection or it's an ABO incompatibility. That brings us to the urinary system. So the ability of the newborn's kidneys to filter and reabsorb and maintain fluid electrolyte balance is going to be less than that of an adult kidney. So the urine of the newborn is less concentrated, and it usually has a lower specific gravity than that of an adult. Unlike more concentrated urine we usually are exposed to, the newborn is pretty much odorless, even though it's very concentrated. The other thing to know about fluid balance: the newborn's body is composed of a greater percentage of water. It can be like 75%. So newborns are often born with a small amount of urine in their bladders, and they may urinate at the time of birth. The first void, however, should occur within the first 24 hours. Another thing I want to tell you is newborns typically lose 5 to 10% of their birth weight within 3 to 5 days after birth. And this is actually considered normal. Of course, it can be very scary for patients. Why am my baby losing weight? Am I not feeding them enough? It's actually part of a normal process. I mean, they've been sitting in this hot tub for 9 months, and now they're going to start to lose some of that extra fluid through diuresis. And again, as they have limited fluid intake in the extra environment, and as they pass stool, they're going to lose weight. It's not, we expect it, and usually this weight is regained within 2 weeks after birth. Sometimes it's gained even more quickly if it's a formula fed infant versus a breastfeeding infant. The immune system. So Really, the human immune system doesn't fully develop until well into childhood. So newborns are going to be less effective at fighting off infection than the older child or the adult. Term infants are going to be born with some protections in place, but less so for preterm infants. So immunoglobulin, or the IgG, that provides protection against viruses and bacteria that mom has been exposed to, because she actually will pass that immunity on to the baby. So if she's been exposed to virus in blood, she's also passing on that immunity to the baby. The infant is born with IgG, and that passes the placenta into the fetal bloodstream. So this is a form of what we call passive immunity, which means the protection is temporary. It usually lasts about 3 months or so. The immunity that's generated if we were to administer a hepatitis B vaccine is more of an example of active immunity. We're giving them something that they have to react to, but passive immunity means it's just given to them by the mother. IgM is the first antibody that's produced in response to an infection, and it's also first produced by the fetus. So it helps to destroy any foreign substances like gram-negative bacteria. IgA does not cross the placenta, and it actually has to be produced by the infant. However, they can actually acquire IgA to protect the gastrointestinal tract from bacterial and pathogens, because they get it through the breast milk if mom's breastfeeding. So this is definitely one of the advantages of breastfeeding, is again, they can get some immunity through the breast milk. So that means they have less chance of having infections, a less chance of having problems later on. So that's one of the benefits of breastfeeding for sure. Okay, so the integumentary system. So I just want to talk a little bit about some normal appearance of the newborn. Vernix. A lot of babies are born with vernix on them, and it's kind of a thick, white, cheesy substance, and it's secreted by the fetal sebaceous glands. And this vernix is pretty much fused with the epithelium, so it really is what creates this waterproof barrier in utero, and it's also a barrier against bacteria and also dehydration after birth. So at term, the vernix is often limited to just skin folds. You'll find them maybe in the armpits or in the creases of the elbows and so forth. And it's very normal. We don't have to try and get it off. You know, you can rub it into the skin, in fact, because it's, again, helps with bonding, and it's a natural moisturizer. So it's actually a good thing. The more preterm, I shouldn't say preterm, if we have a post-term baby, like not post-term, weeks, they tend to have more vernix on them than a term baby. Um, I also want to talk about lanugo. So lanugo is this fine downy hair that covers the body and the face of the fetus from about week 16 of gestation, and it usually becomes most abundant at around 20 weeks gestation. And then what happens is the lanugo begins shedding into the amniotic fluid, and it's often seen in more abundance in preterm infants, but some term infants may still have lanugo over their shoulders or on their nose, and that's usually shed within the few weeks after birth. Um, we also want to look for skin variations and note different skin variations, and we might have infants have Mongolian spots. So Mongolian spots are these irregular areas of dark pigmentation. It's usually over the gluteus or the sacrum, and it's very common in infants that have a dark complexion, and it's usually going to fade over time. The size and the location of the Mongolian spots should be documented, because sometimes they can be mistaken for bruises, so you just want to make sure you document them. And again, it's just a normal finding. It's something we often see on darker skinned babies. Stork bites. So the name for that is nevus simplex. These are these deep pink or reddish spots on the eyelids or the bridge of the nose or the back of the neck. And usually we see these more common in newborns that have a more of a light complexion, and these will also fade over time. The next one I want to talk about is the port wine stain, or what we call nevus phlemosus. And this is a non-blanchable discoloration of the skin, and it's usually found on the neck and face. It's typically flat and pink at birth, but it tends to darken and become textured with time. A lot of times, if people want to have this removed, that is an option when they're older to have it removed by laser treatment or surgery. The other thing I want to talk about is nevus vasculosus. This is also called the strawberry mark or strawberry hemangioma. And this is an area of the skin that's raised and it's pretty sharply demarcated and may present at birth, or sometimes it even appears in the first several weeks of life. These can continue to grow for up to 2 years, but then they usually will shrink and fade. Milia. So milia are these little small white sebaceous glands that some babies have, and it's usually typically on the nose. They look like little white heads. They typically resolve in about 2 to 4 weeks. There's no treatment for them, and you just have to let parents know not to squeeze them or anything. Just leave them alone. They'll go away. Another thing that happens in some newborns is they'll get what's called a newborn rash or erythema toxicum. This is kind of a red rash that has these little white papules, and this can occur over any part of the body, and most commonly is seen on the trunk. And this is, again, normal. They're benign. There's no treatment indicated. It'll go away on its own. So you want to be familiar with these variations of the integumentary system. This is a picture, kind of hard to see in the PowerPoint, but it's in your textbook, so you can see that fine downy hair that's just above the around the shoulders. And again, that's usually going to be shed off in the next few days. Here it's kind of hard to see, but these are Mongolian spots, so you can kind of see those darker areas around the buttocks and on the sacrum there. And again, we see this more in darker skinned babies, and we just want to note them because, as you can see, they look a lot like bruises. Very normal. This infant is shown with some stork bites, and you can see them mainly on the eyelids and just below the eye. This is one of those nevus phlemosus, which is the port wine stain. Here, again, you can see this probably better in your textbook, but this is milia, those little white heads that occur. And then this is an example of that newborn rash that can also occur as well. So just remember, these are normal findings and require no treatment. The last thing I want to talk about is the newborn's psychosocial adaptation. So immediately in the first hour after birth, the newborn's going to go through their first period of reactivity, and we often call this the golden hour. It's the most important hour after delivery. The newborn's going to be wide awake, they're alert, they're kind of interested in their surroundings, and we usually have moms who are breastfeeding provide their first feeding in that hour. It just seems to make breastfeeding go so much easier. So again, this is the bonding time. When babies are born, we want to place them in, as long as everything's okay, we're placing immediately skin to skin with mom. We're drying off the baby and putting the baby right skin to skin with mom. One of the best ways to help with transition, keeps the baby warm, and also helps mom's vital signs as well. So great thing to do. And again, it really helps with bonding. And a lot of times the baby will start to get, kind of get ready for breastfeeding on its own. It will start to make more, you'll start to see hunger cues. So this is really the ideal time. So this is the golden hour. Again, best time to get that first feeding in. Usually after the first period of reactivity, the infants are going to fall into a deep sleep. And then the second period of reactivity, the infants usually become more interested in feeding. Also, just some psychosocial adaptations. Just know that newborns have several behavioral states that range from a quiet sleep to crying. In the deep quiet sleep, there's usually no eye movements, there's little response to noise and stimuli, and sometimes these babies are difficult to arouse. When they're in that light or active sleep, the infants will move their arms and legs, they'll stretch, they'll make maybe sucking movements, they might even fuss a bit. They may display rapid eye movement, and they're more likely to be startled with noise or any type of disturbance. The drowsy state is kind of a transition between sleep and waking. The quiet state is, again, that excellent time for bonding, and it includes that first period of reactivity. And the active alert state is when newborns tend to become more fussy, and the crying state may quickly follow if no interventions occur to comfort the infant, and the cries will become more continuous and more lusty at that point. And that is the end of this. So this discontinues our discussion on normal newborn adaptation. So next we're going to move on to nursing care for the normal newborn. I think we'll take a short break here and start up again at 2 o'clock. So I'm going to go ahead and stop the recording, take a break. When we come back at 2, we'll go over the newborn nursing care. Sound good? Okay, so I'll see you back at 2 o'clock.